Hello, everybody. My name is Kang, working as the JACC Asia Pulse Specialty Contents Editor. And this is going to be one of our Cardio-Oncology series. And today we have Wei-Ting Chang from Taiwan, who's going to talk about immune checkpoint inhibitors and the case. With me, there's Dr. Ahn, who is one of our editorial board. And without further delay, Dr. Chang, please.
Thank you, everyone. And today, actually, it's my honor to introduce this kind of special topic for everyone. And this is what to do immune checkpoint inhibit, also called the ICPI, due to the heart. I think most of the viewers will be like me. That's what is this kind of things? Because it's an anti-cancer therapy. It's not usually familiar to the cardiologist, but actually, I think it's just to raise one case. So this is the patient. Actually, he's very famous because he's the former president of the United States, and he's Mr. Jimmy Carter. And he's been diagnosed with melanoma. In the past, actually, it's kind of very malignant cancer. So here we can see from the right side, actually about half of the patient will die within 1 year. But actually, he like the first one received immune checkpoint inhibitors, immunotherapies. And after 1 year, actually, most of the cancers almost gone. It's been diagnosed like a cure, not only like a remission, but like a cure. So I think it's very powerful for these kind of immunotherapies. So this is the three very famous scientists who won the Nobel Prize because they identified the PD-1 and the PD-L1. And what is this kind of drugs? Actually, today I want to just maybe within 10 minutes, I'll quickly go through this introductions about the immune checkpoint inhibitors therapies. But this is like a double-edged sword because it's not only cure cancer, but it will cause a lot of different kind of like adverse events, especially to the cardiac, it will be like myocarditis. But how to diagnose and how to prevent and how to manage this kind of complications is very important, especially in our Asia area. So just quickly give ideas about what's the mechanism of the action of the immune checkpoint inhibitor. So here, actually, we have different kind of immune cells, especially like the T cells. The T cell can identify the tumor cells, and then they can attack tumor cells and remove it. But this is something that's very smart about the cancer cell because they can use the PD-1 receptor, the ligand, as like a call break. So with these ones, the tumor cells will be hidden, from the immune cells. The immune cell cannot recognize it and cannot kill it. But if we suppress this kind of systems, the two less famous receptors is PD-1 and the other was CTLA-4. So currently we have different kind of drugs, the ICPI drugs here have been approved by FDA. And these kind of drugs have been used in different kind of cancers, not only the melanoma, but also like the head and neck cancers and lung cancers and the hepatomas and different kind of cancer have been cured by this kind of amazing drug. But it causes the adverse events like we call this irAE. So this kind of like autoimmune response. So it causes like not only the pneumonitis, but the colitis, vitiligo, encephalitis, and hepatitis, and different kind of complications. It's very severe. So the four possible mechanisms about this irAE, the first one is because the T cells, the immune cells, not to be suppressed anymore. Sometimes like overactive. So the increasing T cell activity will against the normal tissues. And the other thing is about the pre-existing autoantibody will be activated. And the other is about like a cytokine storms and also enhance the complement mediated inflammation. So will also cause a systemic inflammation. So with this kind of irAE, actually the NIH has been raised different kind of grading. So the first one, for example, is about the cardiac complications. We would like a subclinical biomarker or like echocardiography changes. But if the patient have symptoms, even if it's mild, it will be grade 2. If it's like a severe symptoms, it will be grade 3. But if it's life-threatening, it will be grade 4. So from this idea, actually, that's the most of the patient we have a complication about the irAEs to the lung or to the gastrointestines or to the hepatitis. But here we can see even it's rare, but actually it's very fatal, it's myocarditis. So just give one patient's example. So this is a 41 woman with melanomas, and has been treated with the 4 cycles of ICPI. And she developed them with the mild dyspnea, and initially just a little bit of the conduction delay. But later on that she has elevated the troponins and the BNPs, but the cardiac function is like a borderline. During duration about 50%, and the coronary is normal. So, but here with the cardiac MRI and also the histology proof that's a myocarditis. So let's use the very high dose of steroid pulse therapies for 3 days, and later on shifted to the oral prednisolone. And this kind of patient have been finally rescued, but still have a lot of different complications. But this is surprise or not, but actually when we go back to that's 2001, and we feel to see the first publications in Science by Professor HyunJin, who won the Nobel Prize. Actually, they found that the PD-1 receptor deficiency mice will have autoimmune related cardiomyopathy. So it's not kind of surprise because these kind of animals will have this autoimmune like myocarditis phenomenon initially. So currently, actually, we know that this kind of ICPI will cause not only myocarditis, but pericarditis, vasculitis, and also conduction abnormalities like fixed-line syndrome, AV block, high degree. So who is at risk? Because before the treatment, we have no clues about who will develop this kind of fatal complications. But currently, if we do retrogress studies, and we found that actually some patients will be possibly have a high risk if they have diabetes, with apnea, high BMI, treated with melanoma or non-small cell lung cancer. These are possibilities. But I think the most important thing is the percentage actually is not this kind of high, it's about only 1% to 2%. But once it happens, it will be very fulminant at the first few cycles, like the first or the second treatment course. But I think the major thing is it's very different from what the cardiologist is familiar with the virus that have myocarditis. Because to our usual concept, is the virus-induced myocarditis will have fulminant increased troponin or like the decline of the myocardial functions. But for the ICPI-induced myocarditis, it's kind of a little different. Like for the myocardial dysfunctions, only half of the patient will have this kind of symptoms. The traditional increase of troponin or ECG is a lot of different from our familiar the virus-induced myocarditis. So I think we need some new tools and to do the proper like prompt diagnosis so we can do the early interventions. So currently, actually, we have these kind of ideas. If we want to diagnose the immune checkpoint inhibitor-induced myocarditis, and we can use not only the pathology, instead, actually, we can use the cardiac MRI or like the syndrome. The syndrome is like the very nice discussion between the cardiologist and the oncologist because based on the previous history, so we have to make the conclusions that it's a patient probability to have this kind of diagnosis. The other things we can use combine with echo and the syndromes and biomarkers, ECG, and negative angiographies, all these things to make the different diagnosis. Once we've been suspected with this one, and then actually we go through all the possible modalities to make the diagnosis, and later on, actually, cardiac MRI will still be the key. And with the LGE, left ganglion enhancement, and with the elevated T2, and actually we can make the confirmed diagnosis before we do the investigative histology. But if we make a diagnosis, what's the second step we are going to do? Because actually, based on the different kind of grade, if it's going in grade 1 or 2, we just discontinue the immune checkpoint inhibitor. But if it's above grade 3, which means the more severe symptoms, actually we have to consider about the steroid therapy. But with that one, actually, I think the shared decision making will be very important because if we do the high dose steroid or like immunosuppressant, sometimes it will shut down our immune systems and cause very severe infections. So I think this is very key to make the right decision. And it is grateful actually should be permanently discontinue the drug. But this part actually still kind of debate because if the patient need to receive the ICPI therapies, usually like the last line, which means there's no better choice about the cancer therapies. So I think about this part, we have some space to discuss. So this is a natural reviews, and actually is point out the different kind of irAEs. Actually, we use different immunosuppressant. But if for myocarditis, there will be the TNF inhibitors and the combined with steroid therapies. So this is the ESC guidelines. Actually, similarly, this told us that if we start with the pulse therapies and later on we have to shift to the oral forms, prednisolone, and then later we have to follow the myocardial functions and to see that the recovery of it. So, and just to go back to the data in Asia. Actually, I found that several publications into these countries actually have been reported cases about the ICPI-induced myocarditis. And so this is the one that we published in Taiwan. And actually, we just do a single center retrospective studies about the 580 patients received the immune checkpoint inhibitors, and to want to see that what kind of possible clues, what kind of patient were at high risk to have this kind of complications. It would include not only the myocarditis, but all the other like stroke, myocardial infarction, all these kind of major cardiovascular events. Actually found that it's the older males or the patient that receive the therapies for lung cancer, liver cirrhosis, or underlying diabetes will be higher risk. And here is things I think this will be very important, because if the patient have the other side of irAE, like have myositis, dermatitis, or like endocrine toxicity or hepatitis, later on this patient will have high risk of develop this cardio complications. And if the once the patient have this kind of cardiac complications, the survival will tend to be very worse. And the other about the statistics part, actually we found not only these important underlying disease will have high risk with myocarditis, but the other actually we found that 3 patients. Actually, I think these patients should be diagnosed with the ICPI-induced myocarditis, but actually the first time they didn't got the right diagnosis. So only one patient got a low dose steroid, but not the others. Even most of the patients get the mechanical support, but I think they didn't get the proper diagnosis at the first time, and the denied treatment actually caused all these patients died eventually. So I think the alert, both the cardiologist and also the oncologist, and how to work together is always the key. So I think just few minutes, and I want to give a guide about the ideas about what is ICPI and how it's powerful to treat cancers. But on the other side, actually it causes a lot of different kinds of systemic immune-related complications, especially for the heart, because even it's rare, but actually will be fatal to the patient if they have myocarditis. But I think always there's multidisciplinary teams work together and to do the proper diagnosis and the prompt treatment, and this is the key to get the patient to the better outcome. So here, actually, I think we'll get some few minutes for discussions, but only just maybe helping minutes. Actually, I just want to promote that because this year, actually, we are going to have FPSC in Taiwan. This is in May 14 to 17, and I'm very happy to host, and everybody is very welcome. And hopefully, look forward to see everyone, and we will enjoy our time in Taiwan. Thank you.
Yes, thank you, Jan, for your wonderful speech. And it was a very nice overview from the risk factors, diagnosis and treatment and prognosis of ICI-related myocarditis and ICI-related MACE. Actually, it was very interesting to see that you have a paper on this topic, which also nicely showed the risk factors for myocarditis. So, HyunJin, do you have a question to ask?
Thank you, Professor Tong, for your extensive review. I have a question. As you mentioned, I think the use of ICI is increasing worldwide, and it's like used in all kinds of cancer types now, which means that more people are at risk of developing adverse events. It would be best if we could screen all of these patients and predict the risk of developing ICI-related myocarditis, but since our resource is limited, I think it wouldn't be that efficient if we screen everybody. So I'm curious on your opinions, how you are screening people in your clinic, and if you actually do define high-risk patients, what are your criteria? Because I think scores like the HFA-ICOS score isn't very practical in real life. Thank you.
This is very nice questions. Actually, I don't have the exactly correct answer for that. Yeah, but I think this HA score, I think is very useful, but sometimes it's difficult because, the anti-cancer treatments actually have a different kind of possible complications. But I think that for this kind of immune checkpoint inhibitors is very unique because it's very different from the traditional cardiovascular risk as we know, like in the past. Because if you for us, we think that's the old age, like cardiovascular complications, like diabetes or hypertension. So these kind of things will be a traditional cardiovascular risk factors. But for these patients, a lot of patients that have developed this kind of irAEs, they are at a young age and they don't have any traditional cardiovascular risk, as we know. So I think we can do post-op screening. This is what we have been tried in my hospital, but actually I think it's not very efficient because if that's even the baseline, the echo is as normal, or even that's the very low risk factors, the patient, but still they have a risk to develop kind of irAE. So I think the other possible things is about the oncologist. Actually, they have to do the regular check, not only the heart, but the other organs, like the dermatitis or like hepatitis. There will be like the clue that's if this patient have the immune response. And later on, there's a be higher risk they have myocarditis or like even severe fatal organ disease. So I think it will be systemically, they can check not only the heart, but also the ECG, the biomarkers, and also like the muscle enzymes, and also like a thyroid, if they have thyroid disorders. All these things combined, actually, I think will be more efficient, than just only check the echo itself. Yeah, but the other thing is because we will have a lot of patients with this kind of treatment. So if you can think about it, if we will have to do this kind of checkup, actually it will be very time consuming and actually will cost a lot of resources about the health. So I think, just the other possibilities is very nice educations between the cardiologist and the oncologist and the nice communications. Once the patient being referred, from oncologist and with the subspecialty, if they suspect, this kind of patient will have the irAEs, and the cardiologist, they have to be alert and to know that what's the next step. We can do the cardiac MRI, and also we can check any kind of clues about the spatial ECG findings of this patient, and so we can discuss if this time is we have to give the steroid pulse therapies. So I think this will be the other things. I think education is the first thing, and the second thing is then we can try to do a screening, but not only the heart but also the actual cardiac there's an immune response, and there will be a nice clues that we can know if later on cardiac complications will happen. Hopefully answer your question.
Thank you.
Yeah, I also have a question. This is going to be a very, very realistic, practical kind of question. I want to make a situation. You have a patient right now. He or she is diagnosed with a cancer, and you anticipate that the ICI response will be very good. And you use that drug. The cancer response was very good. It was dramatic. However, the patient experienced quite severe myocarditis, and you didn't finish the cycle of the ICI agents. So if you have like 1 or 2 cycles left for that patient, and you still have residual cancer, if that's the right terminology, how are you going to treat this patient?
This is a very nice but difficult question. Yeah. So actually, according to the ESMO guidelines, they will suggest if the patient have grade 4, the grade 4 irAEs, the cause myocarditis, so like a severe symptoms, heart failures, and supposedly we should not challenge the ICPF therapies. Yeah, but if it is like the last chance for this patient, if the because usually this ICPF will be used for if the patient have resistant undertreated value with the other kind of choice. So I think it will be nice to do a shared decision making, because first of all, I think we need to get the patient fully recovered from myocarditis. If the patient have been diagnosed at the first time and be treated promptly with the immunosuppressant or like a steroid therapies, usually this patient can recover soon. But if they still have like some like cardiovascular complications, we have like arrhythmias or residual heart failure or myocardial dysfunctions, they will be, I don't think it's proper to do the challenge, but it's a fully recovered, so it would be nice to do a challenge. And actually before that, we have to share decision maker. And the other thing is, should we try another kind of ICPI? Because we know that the PD-1 and the PD-L1 and also like a CTLA-4 inhibitor. So as we know that we do combine CTLA-4s combined with PD-1s will cause higher probabilities to the myocarditis. So usually currently we only do like a single therapies, but they still have a different kind of brand, a different kind of choice. So if we challenge it, we want to do a challenge. Actually, I would suggest, if the patient is fully recovered, and then later on we do SDN, shared decision making, and also we can try to choose another kind of ICPI instead of the first one. Yeah. Just my opinion. Yeah.
Thank you. Novi, do you have a question?
Yeah. Thank you so much. It was a very fantastic presentation by Dr. Chang. I would like to ask you like a very practical questions. So, that in patients with immune checkpoint inhibitor related cardiovascular, ICI related side effects, how intensive should immunosuppressive treatment be, and how do we decide when the risk of immunosuppression may outweigh the potential benefits?
Yeah, okay. This is also not we always ask difficult questions. Yeah, this is very challenging questions. Actually, I think that the choice between the steroid therapies and also like immunosuppressant, I think it's very like professional. Yeah, because I think it's not the field that cardiologists already touched. So I would suggest to discuss with the dermatologist who is the one that's more familiar with this kind of immunosuppressant, and also the oncologist. But based on the just one slide that I present about the review from the Nature, actually they will suggest different kind of irAE will treat with different kind of immunosuppressant. Like for example, there's myocarditis will be treated with anti-TNF inhibitors. So I will think that the other possibility, because I discussed with the very professional oncologists in Taiwan. Actually, this is what the oncologists will do. Actually, can isolate the T cells from our blood. So because everyone will have a different kind of spatial T cell, I think. So they can isolate the cells from our blood. Actually, they can just try to challenge with the different kind of drugs. We can challenge with the immunosuppressant inhibitors, and we can challenge with steroid or challenge with the immunosuppressant. So we can individualize to know that if this patient will possible develop the complications, irAE, or it will be good response to the immunosuppressant. So I think that generally we can just follow the guideline, follow nature suggestions about what kind of immunosuppressant we have to treat with patient if they develop like grade 3 or grade 4 as a fatal cardiovascular complications, irAE. But the other opportunities, if we want to do like a precision therapy, precision medicines for individual patients, actually isolate individual cells from one single person, and actually to see the treatment response or like immune response in vitro. So I think we can do in advance before we treat the drugs in the human body. So I think this will be another option, and possibly only single case I know they did in oncology field. But I think maybe later on there will be a nice opportunities for us to know if this patient is suitable for this drug or not the others, and how to prevent the complications. Just some ideas. Thank you.
Yes, Dr. Chang, thank you for your time. We had a very nice lecture and also very nice answers for very difficult questions. So everybody will agree that this field, the ICI kind of field, is a field with very large unmet needs. A lot of studies should have been done, should be done, and a lot of points we learn from specific cases that we experience in the clinic. So thank you for your time again. And anybody who has questions might contact you, Dr. Chang. So if you get any emails or contacts, please give them very kind responses.
Absolutely.
Okay.
Yeah.
So thank you for your time again. And this will be the end for our current session for the Cardio-Oncology series. Thank you. Bye.
Thank you. Thank you. Bye.